system in terms of improvement. So the concept of an upstream problem, an emergency department, and a downstream problem, and this is how we're going to address the health system that we have in emergency care, and solutions are simply going to be in one part or another. And we know that's not actually the problem. The problem is when someone in the community thinks they have an emergency problem with their healthcare, and navigating that system and actually be able to work through that. So understanding that complexity is incredibly difficult to work with, but ultimately starts with the person who's going to be the user of that service. And you could see you would design a solution very differently if you conceptualise the problem in a complex way, rather than trying to conceptualise it in a simplistic way, which we know fails. The other problem we have in this area is that often research is not seen as providing solutions to problems. So flipping the paradigm, or servant research leadership, where research is actually there to help establish what the main problems are in the health system, develop benchmarks, so actually we get a snapshot of where we are now, and then help enable and support improvement in those biggest problems. The other challenges we have, and this is from the McKeon review almost a decade ago now, is that in Australia, research and development sits outside healthcare. So it sits often in our universities and our institutes. It doesn't necessarily sit or embed in healthcare or work with healthcare. And so we have a separation of our community, health professionals, researchers and investors, and it's about bringing all of that together. And then when we get into our universities and health services, we have wonderful silos, doesn't matter how you paint them, silos in disciplines, silos in sectors. Our business faculties and social scientists and ITs and engineers don't work together with us, and we don't necessarily reach out to them. And it's often very difficult to break through the silos and work together. We also have a particular understander scope. When we're looking at a problem, we often see it from our own perspective, which is not the same as the end user experience of the workforce or the patient at the front line or the manager trying to improve the system. And as a researcher, our understander scope is influenced by the fact that we have to get grants and publish papers, which often do very little to actually solving the problem. So actually it's really important we all get together and have that collective intelligence about the problems and the solutions. Final problem is we're all down our rabbit burrows. We are specific specialists more and more and less and less. We rarely get to stick our head up, and we often don't seek to work with very diverse people around the different disciplines that we need at the table. And ultimately, we all work in a system where hospitals have one set of metrics, universities have others, research entities have other metrics, and primary care is largely in Australia a private small business model. So we don't have a system that is actually about better health for Australia and about a better health system. Surprisingly though, our health system is not too bad, but it's also not fit for purpose, and improvement's going to be critical. And indeed, Jeffrey Braithwaite, who's about to talk to you, has got some good research around the fact that about 60% of health service provision is high quality, evidence-based. About 30% is probably wastage, and up to 10% may actually be causing more harm than help. So one of the solutions that the government came up with is about probably almost 10 years ago now, was to recommend research translation centres as one of the solutions for embedding research in healthcare and trying to flip that paradigm that we've just talked about. These centres, and there's now 14 of them, although they have not all been formally announced, cover all of Australia geographically, largely. They reach organisations with 95% of Australian academics and it's now about 88% of health services, with some primary care engagement as well. And these centres are designed to embed research into healthcare. We've done a lot of work together around what the key priorities are, and getting access to health data, not primarily for research, but primarily for the purpose of improving healthcare, is one of the most critical ones. And we went through a national process, which I won't go through here, to determine the priorities within this. There were 3 key priorities: virtual hubs or learning health systems to actually be able to work top down and bottom up with our communities and with all of the resources we require to use evidence at the front line and improve healthcare. Another one was about the data sets themselves, and the last one was about building workforce capacity. So in essence, we went through a process of getting a large national and international engagement across the centres. We undertook priority setting and then determined that the most important thing was these virtual hubs or learning health systems. We actually wanted to identify an evidence-based approach for healthcare improvement, not for research, although research was a critical part of that. We went through a very strong engagement process, looked at best practice through systematic reviews, undertook extensive qualitative reviews, developed national and international thought partners, and then have been part of implementing this work since then. Essentially, there are a plethora of publications. Most of them don't tell you about actual impact. So when we went through that and then had an agreed purpose to improve health outcomes across our community through data-driven innovation and care, and to learn together continuously, embedded in the health system to improve outcomes. The most important principle today that I wanted to highlight is that evidence is not just evidence from research, and evidence-based medicine is not simply Cochrane reviews. Evidence comes from our stakeholders. What is the lived reality, the lived experience? It's the patients and the workforce and the system we're in. Then evidence from research and guidelines. Then evidence from practice, which is both data and the lived experience of the workforce at the front line, and then evidence from implementation. And we rarely put them all together, and especially because of our silos. So you can see here, this was the framework that was generated. And as I mentioned, the first quadrant, the first place, is the evidence from the stakeholders and their priorities. Not 75 priorities for improvement in one department, but what your top priorities are. Then your evidence from your research, which is often not integrated into practice. Your evidence from your practice, which has to be iterative and available to frontline operators. And then evidence from effective implementation. Jeffrey's work has shown that most of the implementation we do in Australia in terms of improvement is often ineffective in terms of sustainability and scalability. So how do we make sure we do that better? And this means it has benefits for everybody and all stakeholders, and actually is evidence-based in the way we do it, which is critically about the people, the culture, the standards, and the resources that are needed. And I'm not going to do this in detail. You'll have some really good examples of people who've done this really well, their stakeholder evidence, their research-derived evidence, their data, and this is much more complex. And in Australia, we have an immature data system. And then most importantly and most difficult is that evidence from implementation. And you get some really great examples, including from Dominic Cadillac on the panel and Denise as well, Denise O'Connor, about some of the examples of this. But I think that the primary journey I want to take you here is that learning health systems, no matter which framework you use, are about the principles of continuously learning together for health improvement. Research has a role, but it's not the primary purpose of a learning health system. And we've got a great panel and a well-renowned speaker to speak to you next about how these principles can be applied, no matter what framework you use, to actually drive improvements in our health system. So I'm actually going to hand over, I'm not going to go through this in detail now, I'll hand over to Professor Braithwaite, and if there are any questions, I'll take them on the panel. So just for those of you who don't know Jeffrey, and I think he probably needs no introduction, he's the founding director of the Australian Institute of Health Innovation and the director of the Centre for Healthcare Resilience and Implementation Science at that institute. He's with Macquarie University, and he and his team have done some foundational work internationally, not so much embedded in the system, but studying how to improve the system. And on that note, I'm going to hand over to you, Jeffrey.
Thank you very much, Helena. Look, this is a fantastic session, but you just gave a masterclass and summarised many, many things that people are grappling with, thinking about, and if they're thought leaders, trying to make progress on. So I'm going to really delve into that in a bit more detail for about 20 minutes or so, then take some questions, and then see if we can fast forward what we said, you said, and I said, into a panel discussion to get some traction in this area. So thanks very much for the invite. I must say your work and the work of your group is inspirational for us, and we follow your work a lot. So let me try and share my screen and see if I can get this working. Am I up? Helena, is that working? Angela, is that working?
Yes, yes, it is, Jeffrey. Sorry.
Fantastic, fantastic. Okay, so my talk is in a couple of parts, but what I'm really going to try and do is think through with you a bit more about the learning health system that Helena has so ably put so far. And then think through this other question, which is, what are we aiming for? A learning health system, in a way, is to try and do better in healthcare right now, to use evidence, information, expertise, and harness it in a better way for the benefit of patient care. So that's, in a way, what a learning health system is. It's a system that doesn't do like we do now, for example, in many places, which is keep forgetting the things we ought to do, or not doing them very well, or not having this continuous learning paradigm well embedded in the delivery of care to patients. So we're in silos in healthcare, as everybody knows, and we keep doing good things over there, not learning about it over here, or just not generally putting evidence into practice or things that we know work well. So that's what the learning health system is a cure for, if you want to use that language. But what I'm also interested in is, what is it that we're aiming for a learning health system to do? What is it going to contribute? And the time frame I've chosen is 2030, because we've been doing a lot of work thinking through what might the health system look like by 2030 if we get it right. If we do the things that we think are good now, in 7 or 8 years' time, will we have a better health system? And is the learning health system a good paradigm to help us get to where we want to go? So a bit about us. I'm from the Australian Institute of Health Innovation, a couple of hundred, 230 research groups that do health systems research. We have our own wholly owned by a university hospital that we do much of our work in, but we also work, as you'll see shortly, not just nationally, but internationally, on trying to work with health systems to improve them. So let's start not with me, though, and my research institute and what we do, because I could talk about that all day with great passion and conviction. What does the future of the health system look like to you if we got to 2030 and it was better than now? If we got it right, if we had put in place all the things that we know are good for a health system to be, what would you say? Now, let's take some chat. I'm encouraging interaction, even though it's hard to do it with a mediated talk through Zoom. But what would you say, or for that matter, what Helena or Angela or anybody on the call, you might want to pitch in? So we're getting some people saying truly patient-centered, value-based, that care provided in the community rather than only in the hospital, so not just acute orientated or too acute orientated, seamless end-to-end patient care, right place, right time, better and faster flow through the hospital, as well as care in the community. So I can see some patterns here, an end of professional hierarchy. I'm not sure if we'll ever totally end that, but I guess I get the sentiment. Restorative justice and learning culture, more compassionate, more supportive of health workers, preventive rather than reactive, better communication between teams and professions, equitability. What a lovely word. Okay, can I pause you on that? I don't want to get everybody's view, but I can see some patterns in there. And I think what we're saying to each other is, if we got to 2030 and some of these features were in place, we'd have a better health system. And I think the learning health system paradigm is to say, this is a paradigm meant to help, to get more evidence into practice, to be continuously harnessing the data, turning it into intelligence, taking the patient's perspective into account in the delivery of care to patients. So that sounds great. You already have the paradigm, and that was really good. So let me embellish on what you've already said. The next question is a rhetorical question. Don't necessarily put this in chat, although I'm not stopping anybody using chat. If we're to address the challenges for healthcare and produce the health system that you've started to describe, just through a simple question and chat response, what do we need to do from a research and education point of view to underpin the health system that we'd like to be in, that we'd like to preside over, that we'd like to have as the delivery system. So this is a question I'm going to fast forward into the panel. What research and education do we need to do to get to this very nice aspirational health system that we've begun to describe? So that's for the panel. So let me start my talk. So learning health systems, I think the Monash model, the Helena model and her team is an excellent model. And it's obviously being trialed and tested and put into place right across not only Melbourne, not only Victoria, but elsewhere. It's a model that's being taken up. So the proof of the pudding in models like this, in paradigms, in approaches like this, is whether they get used and whether they make a difference. And this one's starting to. So I won't dwell on that because Helena's already discussed that a little. So what are we actually talking about? The original definition was in the Institute of Medicine's definition a decade and a half ago. But before that, we thought, many of us, you know, we need a system that brings together data, brings together care, brings together science, brings together evidence, brings together different perspectives on evidence, the patient perspective, the clinical perspective, the policymaker perspective, brings them together for a better system that learns continuously. So that's embedded in the original ideas, like this slide, and then providing the right cultures, the right incentives, and the right leadership to make this system happen across time. So you get all sorts of stuff like this, Learning Health System Framework, which has science and informatics, patient-clinician partnerships, incentives, continuous learning, and you get models like this saying we have to build the infrastructure, mainly around technology and data, so that people have data at their fingertips at the right time to deliver what someone said in the chat, the right care at the right time, to the right patient, for the right cost, with the right data. Not only clinical data, not only evidence from PubMed or Medline, not only the patient perspective, not only PROMs and PREMs, not only genomics data, but all of that together to try and get the right care delivered. So we've brought the literature up to date. Here's some steak knives for people. Recently, we published a couple of reviews. One is a review of what does the literature on learning health systems say. So we did this scoping review, brought together all the literature and said, what are the key things in the literature that are telling us about creating a learning health system? I know you can't read this very well, but it's an open access paper. If you can't find it, tell me and I'll send you a copy personally. But these are the concepts inside the network map of what's in the literature. People tended to start with a learning health system definition, the IOM original definition, the Institutes of Medicine, which has changed its name now, in the US. And the key topic areas were about not just electronic health records and improvement in medical informatics, but also using big data, embedding data, making routine delivery care processes more evidence-orientated. So we published a second review just this year where we looked at, well, what is the science of learning health systems saying? What are the studies that have been done on learning health systems tell us? And these are nice complements, we think, to Helena's model that she is explicating and built up from the ground that's fit for purpose for many health systems, and many health systems are using it. And this was 76 papers, mostly from the US, the UK, and Canada. These are the empirical studies. Half of them were quantitative, a third of them were qualitative and mixed method. They basically were studies focused on how do you implement a learning health system. Very few studies explicitly incorporated that's implementation science, not implantation science, an implementation science framework. So they weren't really using some of the things we've now invented in the last 10 years or so, which are good models for how do you implement complex interventions in healthcare, because that's what a learning health system is. It's a complex change, a complex improvement, a complex intervention, if you like, into the health system. Here's what the empirical research said in terms of key words. What we ended up saying is there's been an increase in studies. Research predominantly focuses on getting things in place, platforms or data that assist in achieving a learning health system. There's a lack of good research. Most of it's a bit anecdotal, or N equals 1. This is how my health system is becoming a learning health system. And there's increasingly a use of frameworks to help guide people in their improvement using a learning health system type work. We also published a couple of years ago, predating those literature reviews, a white paper, which has been quite taken up by many people. And essentially it went somewhere to defining a learning health system, evaluating a number of case studies, prominent case studies in different parts of the world who were indicating they'd made progress in becoming a learning health system, looking at barriers and enablers, and evaluating frameworks. And we added something in this white paper to the IOM definition, which was to get the structures and governance in place for a learning health system to journey to be furthered. So the case studies, I'll briefly deal with this because I want to get to the future and what 2030 might look like if we get it right. Case study from the VHA, that's often rolled out as a good case study for many things that are inventive and progressive in the US. And you can put the VA and where it is in terms of a learning health system inside this framework, which we've done in this white paper. Geisinger, some of you know about Geisinger in the US, in Pennsylvania, a large health system that is also very progressive and making progress in harnessing data and trying to produce good quality care to its patient population. Again, we put this system into this framework. The Ottawa Hospital in Canada is also mooted as a demonstration site for making progress in transforming and harnessing learning health system principles. Again, in this white paper, we put this into the framework. And we've been doing some work in our own hospital at Macquarie University. We've got a large, thriving general practice. Not many people have put the learning health system ideas into a framework outside of hospitals or health chains. So we've been trying to apply this in learning health system principles in general practice. To get over that problem that we too much perhaps do work in acute settings and not enough in other parts of healthcare. And this is coming out in the British, there's a paper on this coming out in BMJ Open and another one coming out in the British Journal of General Practice soon. These are forthcoming. And again, we put this in a bit of a framework to give structure to what progress were people making of the journey of the learning health system. So, okay, that's by way of preamble. All I've done really so far is perhaps brought colleagues' knowledge up to date that there's stuff going on about learning health systems that's useful, and maybe over the break, whilst you should have a good break and recharge your batteries if you're taking time off soon, you might want to access some of those papers and bring your reading up to date, because we've brought the learning health system research literature up to date with those 2021 and 22 papers, and they are very complementary to the model that Helena developed that's so compelling. So, for my sins, I'm the series editor on a couple of series of books, and this series is on international health reform across the world. I could take a poll and ask who has read these 3 books on health reform across the world, but I may be disappointed, although I do know that these books are very interesting compendiums. The last one was 500 pages of what's going on across the world in low, middle income and high income countries. And so they're kind of useful. And even if you don't buy one to read it, they look really cool on your bookshelf if you're doing a Zoom meeting just behind you. I'll keep the humor down a bit. So the first book was in 30 countries, and we asked authors in low, middle income and high income countries, low, middle income and high income countries, what are you doing about quality and safety? And can you tell us the progress you're making? And so you would be not surprised to learn there's lots of different projects going on, policy into practice type projects, research projects, quality improvement initiatives to make care safer and of higher quality across low, middle income and high income settings in those 30 countries. The next book in the series we did was we asked 60 countries, could you tell us a success story in your country to do with health reform or improvement or an intervention that you did that worked really well, that worked out, or evidence-based care where you've made particular progress. And this time we had 60 countries, low, middle income and high income countries, and they all told us a success story. It's a nice compendium of, you know, sometimes we think about the doom and gloom in healthcare and worry about it too much. There's a lot of success stories to be told as well in Australia and elsewhere. And it's the third book that I want to focus on. The third book asked a lot more authors in a lot more countries, what do you think is going to happen if you get it right in your health system? Low, middle income and high income countries. What might that help us to do to shape our thinking about what health system we might like to become in your country by 2030? So here's the book. You can get it if you like, or you can just listen to these slides because I've summarized it for you. It's got 146 authors covering 152 countries, and there's only 190 countries in the world. So this is a big slice of the world. And if you like, this is a wisdom of crowds book. It's the kind of book where we captured many, many thought leaders, researchers, policymakers, influential people, observers, patient advocates who are all thinking about, well, what might the health system be like if we get to 2030? And we've had some success. If you want a summary of it, and don't tell the publisher this, we did a summary of this in the International Journal for Quality in Healthcare. The publisher's going to kill me one day because I'm reducing their capacity to sell this book, but it's selling pretty well anyway. It doesn't have everything in the book, obviously. This is just an article, a few thousand words, but we try to capture most of it. And I'm going to talk about what this looks like now in the rest of the talk. So get the paper, it's on open access if you can't afford or it isn't your thing, this isn't your area and you don't want to buy the whole book. But the book is very instructive and it's a book you can dip into a lot. So what lessons can be taken from this global outlook on the future? All the countries with colours are the ones that are in the book. So the greyed ones, the grey out ones, some in South America and a couple in the Middle East, weren't sort of covered because we couldn't get to everybody in time. But what did the book say? Well, it's a 5+9 model. So just think about this as a 5+9 model. The first thing the book said was there are 5 main trends running through health systems. These trends are everyone's trying to figure out how to create systems that are built to last, that are sustainable. Everyone's trying to figure out how to harness new data that comes along, like genomics, so they can get to precision medicine or more informed targeted treatment, the genomics revolution. Everyone's trying to exploit new technologies. And I mean, not just IT type technologies or diagnostics, but new drugs. You know, if new vaccines, if the pandemic taught us anything, it's that science is amazing and that we could produce a vaccine for COVID-19, several vaccines, in fact, in only a few months. I thought it was going to take about 2 or 3 years. But science really has come on amazingly in terms of its technological capacity and ability to deliver new things to health systems. Global demographic dynamics, largely that means the populations of the world are aging, populations of Australia, the population of Australia is aging. And that means new challenges for health systems with more chronic and complex diseases. And new models of care, more distributed care. And again, the pandemic was instructive. It forced us into taking up telehealth, telemedicine, teleconsultations, and other modes of delivery much faster than we otherwise would have done. So these are the 5 trends that seem to be running through. This book was pre-pandemic, 2018, and it was a bit prescient. These are the trends that are still running through health systems, even now that we're 2/3 of the way into the COVID-19, maybe, well, we hope. These are happening now in any case. There's nothing we could do to stop those. These are trends. We think we've captured the zeitgeist of medium to longer term trends running through even low-income health systems. And there were 9 areas that were activity areas that were being widely promoted or adopted to get us to 2030. And you'll know these because these are happening in Australia, but they're happening everywhere, it turns out. Trying to have more integrated, joined-up health systems. Trying to get enough financing and economics and insurance money into the system so it's adequately resourced. Working on patient-based care and empowering the patient, PREMS, the patient voice. Trying to move towards more universal healthcare. Now, that's a pointed message to the US, but many low or middle income countries don't have universal health systems. One of our worries about Australia is, are we moving away from a universal health system? And do we rely too much now on people's capacity to pay for some kinds of care? So co-payments. So one problem we've got is, to what extent is Australia becoming a less universal health system? Although I agree, we've got a very good public health system, which serves people most of the time. The 5th thing is technology and information technology. How do we get the new IT, the new diagnostics, the new drugs, the new vaccinations in place and in an affordable way taken up? Those are the first 5. The next 4 you will also be very familiar with. Aging populations. How do we deal with aging, frail populations requiring more care, more residential aged care, more with chronic and complex conditions? An emphasis on prevention, not just acute care. Getting the system right in terms of structure, accreditation, standards, policy, and then human development, education, and training. That is to say, if we're going to produce a new shiny health system that's very technologically enabled and has all of these things going right, the workforce of the present isn't going to be the workforce of the future. It's by definition not fit for purpose, because all these new things have to be dealt with, managed, delivered, exploited, used. So the human development, education, and training is the 9th activity people are developing and working on, but it's probably crucial. It's probably the most crucial thing. Now, here's a slide for you. I've crunched all the 9 into my answer to the question that I started off with you in your chat discussions. The system as we know it is very good. The Australian health system is very good. Many health systems of the world are very good, but they're not altogether good, are they? Our system and other systems tend to be more fragmented and siloed than we like them to be. They're not as joined up. They're kind of volume-based still, although we've been talking about value-based health systems. They're a bit more provider-oriented, but we're on a pathway to becoming more patient-based, person-centered. There's a lot of barriers to access and affordability. Perhaps we're building more of those in Australia as we go along, rather than universally covering everybody. In terms of IT, we've got lots of static legacy-based systems. We're not very data-driven at times. It takes us 2 years to get information from AIHW or sometimes the state health system or the feds before we sort of then can work with it. We want to be much more fluid and machine learning, AI-enabled, data-driven. We want to have decisions, data in the hands of clinicians. We want to be more information technology savvy. Unhealthiness amongst the population, poor health literacy. We want much more healthy, health literate populations with well-being as a focus, healthy aging, health aware. Preventive care, we focus still a lot, even our research is still a lot on hospitals, acute care settings. We need to shift much more, shift the dial towards more primary oriented health promoting preventive care. Quality and safety, a major feature of our research, and I know, Helena, your research. We've got entrenched levels of poor quality, unsafe care. 10% perhaps is the rate at which we have adverse events. We want less harmful, more effective services. And then uneven workforce training, knowledge and development. We want a fit for purpose, highly trained, sustainable workforce able to meet future patients' requirements. So those are the 9 things. If you add the 5 trends running through health systems to that, that's a blueprint. We think the wisdom of crowds, 148 authors covering 152 countries. We tapped all that wisdom and produced that in this slide to say maybe that's a good take on the health system of the future. Bear in mind, without hearing this talk, you said much of that in your chat input already. So I kind of think we've got the blueprint we might need. The trick will be, how do we go across the next 8 years or so to create that system? The system that we all want to provide care in, receive care from, and see delivered to the Australian population. A rhetorical question again, I'm going to fast track that across to the panel. Are there any other trends or themes that maybe we've missed or you think are important for us to factor in that aren't covered in that blueprint for the future, that template for the future? So a couple more parts and then I'll finish and we'll hand off this to the panel. The interesting thing was that book was published, that 3rd book in the series was published in 2018. So it's pre-pandemic, but I think it's withstood the test of time, but you can be the judge of that. In that same year, there were 3 remarkable other things happened. 3 big international reports were produced at the same time as this book was published in 2018. Now, you know that idea that science proceeds where an idea whose time has come gets invented simultaneously in a number of places. That's the history of science. Often there's a breakout year when a number of things happen simultaneously, and that tells you something. Well, we kind of think this is that year. The Institutes of Medicine, which became the National Academies of Science, Engineering and Medicine, wrote Crossing the Global Quality Chasm, Improving Healthcare Worldwide, a major report that is very complementary and synergistic with our big book, our big 500-page book of 148 authors. The Lancet Global Health Commission put out a fantastic report about health systems and their progress with the Sustainable Development Goals. And the World Health Organization, World Bank and OECD, who I work with a lot, produced this Delivering Healthcare in a Better Way book, delivering higher quality health services in the global imperative in the same year. So Don Berwick, a colleague of mine who many of you know, wrote an editorial in the BMJ about this. We published a paper in BMC Medicine, one of the medical journals, saying, if we've got all this knowledge now stacked up, this 3 reports and our book, what does that mean in terms of transformational improvements in quality care and health systems over the next decade to take us to 2030? So you can read that. It's on open access if you haven't already. Basically, these are the themes and concepts in those reports, in those 3 reports. I've synthesized all that for you. And it's what you might see. That's what you see on the tin is what's in the reports. Here's another way of looking at it. These reports are all about health and care and systems, taking a systems approach to improvement. They're about quality. There are lots of countries involved. They provide lots of examples. It's a global perspective, aggregating country experience. It's about mortality, access, it's studying systems and improving delivery systems. So that's a snapshot of what's in those reports. You probably don't need to read them now because my slides perhaps summarize it sufficiently for many people. So what did we say in that paper in BMC Medicine that takes those 3 reports and our book to the next stage? We said each country should develop a blueprint for change. They should have a plan for 2030 and should be based on all this material, but modifiable to the country's circumstances. In Australia, we don't really have a health plan for 2030 that's clear. We have plans for some things, but we don't have a clear plan for where we'd like the health system to be. We think this is useful to take into such discussions. We need to make tangible steps to reduce inequities within and across health systems. Some health systems need this far more than others. Low and middle income countries really don't provide care to a lot of their population who are living on $1 a day and in poverty. But even in wealthy health systems, there's inequalities, inequities across the system in terms of delivery of care. And we know that in Australia. And then the other plea from us is we can learn from books like this and papers like this from what goes right. We shouldn't just demonize the health system or say, woe is me, or it's all stuffed, or things are going wrong all the time, or, we've got a burnout workforce and, we haven't got the technology we need. We haven't got enough resources. A lot of healthcare goes right. So we should learn from that as well, is our plea. So if 2018 was the year of analysis and reports, and then we had a very instructive but hard to deal with pandemic, which is still on, can the 2020s be the decade of action? And can we hopefully get over the pandemic sometime in the not too distant future, and then create a learning health system, a fit for purpose health system, a really fantastic delivery system by 2030, perhaps in the way I've discussed in the blueprint I've just laid out. So for the panel, for you, what are the implications for each of us? Each of us has a different role. I'm a researcher. Some of you are clinicians. Some of you are policymakers. Some of you work for safety agencies in Victoria and elsewhere. We all have different, some of you are patients and patient advocates. We all have different roles. What are the implications for you? My question is, firstly, do you agree with the version? I think it's plus or minus that we could tweak this, but that version's largely sustainable, not a bad target for us to pitch for in terms of where do we want the health system to land by 2030. So how do we get to this version, or a modified version if you want to tweak it a bit, of 2030? That's my plan, plus the 5 trends. You can have your plan or tweak that a bit if you want to use this model. There's many ideas about transformation, by the way, and I'll finish with this. So many people talk about, well, how do we transform a health system once we've got a model like this? WHO has this model. There's lots of other models. We are not lacking models at the systems level about how to transform the health system across time. The trick is how to do it, and then how to agree on what our target is for getting there. So there's a lot of change management models. That's all I wanted to say. I hope you enjoyed listening. I certainly enjoyed putting this talk together for you for this special event. I can take Q&A for a few minutes. I hope I've left enough time, but otherwise we can morph straight into the panel and start to discuss some of these issues if you wish. I'll stop sharing.
Thanks very much, Jeffrey. Thought-provoking as always. And we do have a little bit of time for questions before we go to the panel. So there's just a few comments in the chat I might just highlight. So quite a few really fantastic comments in there, and I would encourage all of you just to have a focus on that, but really strong emphasis around patient-centred and value-based care with a focus on prevention, care provided more in the community than in our ivory tower hospitals, where most of us would prefer to receive that care. Focusing on the experience of the end users, so the workforce and the patients, and end-to-end seamless care. So there's some very similar messages in response to some of your prompts there, Jeffrey. Also, things about being preventative rather than reactive, which fits with your safety program, and I think that's really important. We have an error in the health system, and there's all this focus on that one event and not necessarily on changing the systems around it. So I think they're the main things. There was a question about your links for the books. We'll try and put them in the chat during the question time, but if we don't get there, we'll circulate them to everyone who attends after the meeting as well. But Jeffrey, if you get a chance to put some of the links in the chat during the panel, that would also be fantastic. So I'm just going to open it up to questions. Anybody specifically have any questions for Jeffrey before we move to the Q&A? And I'd really encourage our health service providers and innovators in the, on the call to link in if they wish.
If the link doesn't work, by the way, Helena, people can just Google my name and the book,
Yep.
Health Reform Across the World, Global Perspectives, and it'll take you to Amazon. So and there's a summary in Amazon as well, and then they can go straight to that open access paper if they prefer.
Not a problem. So Jeffrey, there's a question here: is data our biggest challenge? And I'll get you to answer that, and then I have a comment as well.
So data is a big challenge. There's lots of health systems are awash with numbers. We create data, but much of it is static. As I said in the talk, legacy based. It's stuck somewhere. Sometimes we get it and it's 2 years old, or even if we get it in a timely way, it's really just numbers. It's not turned into information, and certainly it's not intelligence there when we need it at the right time. That's the whole predicated, what the learning health system is predicated on. So data is a big problem in my view. We're not going to solve that soon. It's a bit like a journey rather than a destination. But the other big thing is people, and whether they are trained and skilled to use data in appropriate ways. And it's having data that's useful for patients to make decisions as well. Because we're not very good at, we're getting better at eliciting patients' views, proms and prems. We're not so good at giving patients the right sort of data and to help them make the decision about their own care and be co-creators of their care. We're still at an early stage in that revolution.
Yeah, no, definitely. And I think in responding to that, data is essential but not sufficient. And the dynamic data you're talking about, and there are some really interesting models emerging where data is not just the blunt tool. Even dynamic data itself is not enough, which is why there's those elements that no matter what learning health system framework you use, they bring in all of the elements around the people, the workforce, the system they work in, the end users, the people who are subject to that. So there's another one, Jeffrey, just final question. Is sustainability about money or about doing things better?
Depends who you are. If you're the government, sustainability is about money. And the reason is, if you see the graphs, I didn't show this graph, but if you see the graphs on how much healthcare is going to cost as a proportion of GDP, it's sort of like going up. And if you extrapolate it, it looks very scary. So people think we can't afford this level of healthcare for everyone. So for some people, it's about money. I think you're right. This is about us doing things better, more efficiently and effectively. If waste runs at 30%, or even if it runs at 15%, that's what estimates say. Waste test results that never get seen, care that shouldn't be delivered, but it is, administrative duplication and burdensomeness. There's lots of ways to waste money. Choosing wisely stuff where we do things that maybe are marginal. So if we have waste in the system, whether it's 30%, as some estimates suggest, or it's less, if we could save some of that, we don't have to have a better health system. We could just redeploy that into better healthcare, into more productive uses of the money. We'd instantly have a better health system. Now, it can't be easy to do, because if it was easy to do, we would do it. So it's a non-trivial question. However, I think sustainability is about that, doing things better, using resources more wisely, and thinking about, can we afford all the care that we currently produce? Or a better question is, how can we afford all the care that we're going to be able to produce across the next 20 years?
Yeah, if you look at maternity care, Jeffrey, the cost of public maternity care has gone up 48% in 6 years, which is so completely unsustainable. It's not funny. I'll make a final quick comment to the last question in the box, and then we'll go to the panel. There's a question about the plethora of data and competing priorities and how do we set priorities. That, again, doesn't matter which framework you use. One of the tenets of a learning health system is you do set priorities, and you don't set them yourself. Whether you're government, an academic, a clinician, or a hospital CEO, if you want everyone working with you, you set them through collective intelligence, and you bring everyone together, and it's agreed about what that priority is, and then people get in the boat and row with you. There's quite interesting evidence around, for example, top-down learning health systems don't work if they're primarily government-driven. Bottom-up alone don't work because they need the culture and the system. We need everybody in the room, and yet so often the assumption is that one group or another group will do this, and we obviously all need to be in the tent together. But on that note, I'm going to go to the panel, and I just note that Professor Andrew Wilson's joined us. Thank you. So I'm going to introduce you to the panel very quickly. So obviously Professor Jeffrey Braithwaite will be a member of the panel. Professor Andrew Wilson, who's the Chief Medical Officer in Safer Care Victoria, and a cardiologist who's going to hopefully tell us a little bit about the cardiac learning health system. Professor Dominic Cadillac, who's a health economist and also has a healthcare background, who's the head of translational public health and evaluation in the Stroke and Ageing Research Centre at Monash University. Associate Professor Denise O'Connor, Co-Deputy Director of the Monash Department of Musculoskeletal Health and in the Clinical Epidemiology Department of Monash. Denise is a true implementation researcher, deeply embedded in working with healthcare. And Dominic's got some spectacular examples of great work that they've done. Sarah Lorenz is the strategic advisor to the CEO at Monash Health, one of the largest health services in the country, and has a strong focus on improvement within within the front line of care. Robin Hudson, who's the Chief Operating Officer at Safer Care Victoria, again, a very strong focus on improvement and through maternity care. And I'm going to ask them all to basically to give us 5 minutes about who they are, and then we'll give them very specific directed questions. And I'll do that as I go around. So, Andrew, I'm going to start with you and just ask you, is there anything else you want to add to your introduction? And can you describe the cardiac LHS, the learning health system, and perhaps provide some insights and perspectives on what you think this is going to look like, just in a 5-minute snapshot for us?
Sure. Thanks, Helena, and thanks for everyone's attention, and thanks for the opportunity to speak. I think as we've had lots of goes at collaborating, so this is great to be all in the same room together. I think that our secretary, Ewan Wallace, who's the head of the health department, is a academic clinician from Monash originally, as many of you know. So he's definitely very supportive of this way of thinking. He's been talking about it well before he came from Safer Care Victoria originally. So that's a huge asset for what we're all trying to do. And that's filtered through the organisation. There are some other key people who absolutely are on board with this kind of thinking. In terms of the cardiac learning health network, once we moved in the direction of setting up some learning health networks, why choose cardiac as one of the initial ones? It was based on existing work that had already been underway. We have a program of improvement in cardiovascular care within the department that was already planned, so it made sense to piggyback onto that already established work. Clearly, it's a very important and key part of healthcare, but also equally, we have some programs of work which hopefully will really start bearing fruit next year, which are very significant linked data programs that are looking to permanently link data with the hospital data, but also with MBS, PBS Commonwealth data at a range of levels. And so what we see there is a really key backbone to this work and other work that will actually hopefully put Victoria in a really world-leading position where that data linkage, one of the main reasons it was set up was to feed data into these kind of improvement programs and look at population inequity, variations in care, but also understand in our system. And as you all know, data availability and linkage is a really key plank to any kind of learning health system. So we're very committed to this program of work. We absolutely see it as a partnership, and Helena and I have spoken about this offline before. We do not see this as a top-down program. We absolutely, and I think having Safer Care Victoria, particularly in the way we approach things, key players in this, we absolutely see that bringing consumers, clinicians, academics in is critical. One other quick thing may come up in questions. I'm sure many of you know, with the election, medical research is coming back into health, Department of Health, which is very pleasing for all of us. And we've really got some work already underway to really strengthen and build our partnerships that we have with you. So really have formal, sustainable, enduring partnerships with the sector and academic sector. So clearly this is a great vehicle to do that.
Great, thank you very much, Andrew. So the next one is I actually asked Dominic Cadillac to give you a little bit of insight into really the spectacular example of the learning health system that's been applied in stroke across all those dimensions of the learning health system we've discussed. Dominic.
Thank you. So just in case people don't know, I'm the data custodian for the Australian Stroke Clinical Registry, and I've been involved in this type of work for longer than I care to remember, but it has evolved over 30 years at least from when the first National Stroke Strategy was established. And from there, we've had clinical guidelines developed, and that really helped shape the way in which we would measure access to best practice care. Now, on the background of the fact that our guidelines program often relied on funding, and the last time they were up, there's a 7-year gap between the 2010 and the 2017 ones being updated. We're very fortunate to be in a position with technology to be one of the first global living guidelines consortiums that worked with the Cochrane collaboration to set up a living guidelines program. So this means as evidence is it's all now placed in, software. And when we need to go through specific reviews of the evidence, we can then update our recommendations and pass out that information. And there's been work published on that, or is coming through on the Living Guidelines program. And that framework really helped with the COVID-19 Living Guidelines program as well. So I think what I've seen over the last 30 years is that we've come a long way, and we're at a real, within Australia in particular, we're at a real turning point. So with the Australian Stroke Clinical Registry, we collect patient-reported outcomes. That data are directly fed back to clinicians. People can access benchmark reports. We're moving into the era of dashboards that allow you to drill down into specific aspects of care or particular features of patients, which we haven't been able to do before. And through our pilot projects of data linkage, we know that we can draw out high quality data. So Andrew mentioned the fact that there's the the linkage maps and the data linkage that's happening across different parts of the data assets that are being held by the Victorian government. Well, I'm pleased to say that the Australian Stroke Clinical Registry is part of that linkage map, so greater insights into stroke can occur. So we have ways in which we know what best practice looks like. We have ways in which we can measure whether or not people are being or are receiving care. Yes, we have seen some areas of best practice care stagnate, in particular within the rehabilitation phase of stroke. We haven't seen much movement over years of auditing within that area. Where we've been able to do active facilitation and run programs such as those that follow a plan, do, study, act model, which is where we actually go in, we help the clinicians interpret their data, we develop evidence-based strategies, and we have a site champion work with the interdisciplinary teams to execute that action plan, to address why we are having barriers to those practices. We have seen quite important shifts in the way in which people are then delivered care. So up to 17% through our audit and feedback programs, when you add in active facilitation and evidence-based strategies to achieve clinician behaviour change. However, these things are very difficult to sustain. They're often one-off projects, and this is where the difference comes from quality improvement programs and a learning health system. And we've spent a lot of time trying to understand how we can embed and work with greater automation, greater pooling of data, because what we don't want to do is have clinicians that need to be looking after patients just spending all their time collecting data. We want to use software technology advances in the way in which we can extract data and use data, so that clinicians can focus on the improvement part and not so much the collection part, where we see, often they have no capacity left to do anything else. Pleasingly, from 2017 to 2020, with this embedded model where we do adapt and we have data routinely collected, we have seen shifts, in particular for people getting hyperacute antithrombotic therapy, having their swallowing assessments and things like that. We did see a dip with access to stroke unit care in 2020 related to the COVID pandemic. And we were, using our registry data to directly inform, for example, the Victorian government on the unintended consequences of COVID on other services such as stroke services. So this is where a living learning network is harvesting and utilising the data from a registry where you've got continuous collection, and we can readily pull that data and provide information in. So I think I've covered most of the key points. I think the other thing to mention is that with the Commonwealth Department of Health, the Clinical Qualities Registries Implementation Group, we are bringing together different registries, so we stop reinventing the wheel. Where we've seen registries make progress in automation or the ability to have interoperability with state government held data sets or EMRs, we are working towards that as well. So I might leave it there.
Thanks very much, Dominic, and I think you've written up the way it aligns to the learning health system really well, so that paper will be coming out soon. So the next one is, and we'll keep all questions to the end. So Denise O'Connor, as I mentioned, who's an implementation researcher at Monash Uni, and this is actually funded work from through Safer Care Victoria and with the state government on funding a startup initial learning health system model. And this is one of the key projects that emerged. So Denise, can you tell us a little bit about the approach you took?
Thanks, Helena, and hi, everyone. As Helena said, I'm an implementation researcher, and I'm director of the Cochrane Effective Practice and Organisation of Care Group Satellite, Australian Satellite. And so we produce reviews about on evidence of interventions or strategies to improve healthcare delivery and systems. And so it's all about drawing on evidence about what are the barriers to change and what is the evidence base, the empirical base and theoretical base in research, translation, health professional behaviour change, shared decision making, all of those sorts of concepts. And so I guess in terms of thinking about a learning health system and my particular area of interest, which is about, optimising high value care and reducing low value care, there's lots of synergies with those two processes really, and probably the most obvious one, and I think Helena talked on that before in response to a question from the one of the participants, is about getting that early stakeholder engagement, and that's really critical in any area where we want to actually achieve behaviour change, complex change, and actually bring everyone together to actually identify what are the important priorities to address, and all get in the boat together and work towards a sort of a common goal. I think the other alignments between learning health systems and low value care, again, in the project that we've undertaken as part of, working across the 3 academic health science centres in Victoria, but in other projects as well, is the importance of not only drawing on evidence from clinical research, systematic reviews and evidence-based guidelines, but actually drawing on the empirical evidence base about implementation science, about behaviour change, about how to understand and what are the drivers of change, and also what are the most effective ways to actually achieve research translation and behaviour change. So, I mean, they're the 2 big synergies. So in terms of the pilot project that we commenced as part of the work within Monash Partners, but with the other 2 Victorian academic health science centres, is that we said we want to actually optimise care, particularly given the environment of health services facing the effects of the pandemic and the pressures that they were facing. But we didn't select the priority. We didn't identify what the low value care was, but instead we brought the key stakeholders together to actually work together and identify what were some of the key pressure points that might add value to the system and help reduce pressure to work towards, bringing about change. So really that was our first step, and that's an approach that we bring to many problems, is that we bring those key stakeholders together in the first instance. So, I mean, unlike Dominique, who works, in stroke and their network has achieved so much with that concentrated effort over many decades, I guess I'm topic agnostic in that I come and work in any area. And I don't have a stake in what the topic is, but it's really about the process, the approach. And so that learning health systems approach is a really, important one. And of course, implementation science, we're all about using data to gain insights and to actually develop intelligence. So not just having lots of data, but actually making that meaningful so that we can interpret it. So I might just leave it there and hand over to the next person.
Thanks very much, Denise. And it's been great to see that, you've actually delivered tangible improvements in healthcare aligned to guidelines. Sarah, perhaps if you could address how the processes involved in the LHS could assist a large organisation like Monash Health, particularly, for example, in areas like setting priorities. Our emergency department has 74 improvement priorities. So how do you think this might be relevant to what you do?
Thanks, Helena, and thanks for having me today. It's a really great model, I think. I'm just going to take a quick trip around the wheel and talk about some of the really key points for a large health service like Monash. Just for those who are not Victorian, we have 22,000 employees and we cover, nearly a third of the state. So I think the engagement side of things is really key as a very first step. In terms of really having a good strategy related to both interest and influence. And the patients and the consumers have got to be at the heart of that. So, we have a structured way of doing that through consumer advisory committees. But I think we also have to think of really bespoke ways to engage this really important group. So, using technology, addressing communication barriers for perhaps cohorts that don't typically are not typically able to influence the health system. And then obviously the clinicians, that frontline voice is absolutely vital because they are the experts in terms of service delivery. Alongside, the whole sort of the health services, which have a broader view and the alignment with strategic planning, regulatory obligations and overall reform agendas. In terms of the government, I guess we really want to provide opportunities for government departments to see the issues firsthand so that they can really make informed decisions. And also with regards to research, I think it's, we have to go beyond just academic partnerships with universities and institutes. Really good to hear kind of reference before me about joint academic and clinical appointments, so that it's really embedded in the structure of a health service and not just a partnership. The priority side of things, yes, it's a big challenge, and particularly for a large health service. So some of these priorities are defined for us by government or by our regulators, but those internal priorities, what are we really going to go after? And Monash has had a little bit of a shift over the last, over the last year, in terms of really articulating a small number, so 5 major priorities that we're going after as an organisation. And, that's taken a lot of steps, as you say, getting away from having 70 priorities. It's really getting a focused conversation about what's really important for us in the next year or in the next, 3 to 5 years. Just briefly on the evidence-based information, I think, the creation of homegrown evidence is a great opportunity for us, which would be facilitated by an academic partnership model, so that you have leaders within the organisation who are involved in creating the evidence. And that also doesn't have to be limited to just clinical evidence. So, we've got finance and workforce and digital realms that are really important to the functioning of our business. And then taking that evidence quickly into benefits for the patients and the organisation. So we've obviously got the Monash Health Translational Research Precinct, which is, really key to that process. But incorporating this kind of evidence quickly into our policies and procedures and guidelines. And I think we know we can do it. The pandemic showed us that we can, but we need to keep that momentum going. Data and information systems, where do I start? I think, it's really about timely, accurate and meaningful data that can be used to guide decision making at the point of care or the point of service delivery. And that's kind of the holy grail for us, I think, in health services. But what we have is multiple systems that don't necessarily talk to each other, lots of manual processes, a lot of manipulation of data to kind of fashion it to what we need to make decisions. Often we're quite beholden to vendors who have may have a different agenda to us that may be more financially driven. I think there's huge opportunities to leverage artificial intelligence. That's seen as an opportunity and not a threat. And also obviously on the background of a really robust cyber security framework that can keep all that data safe. Benchmarking, again, I think, the establishment of things like the Health Service Partnership has really sort of helped facilitate that process locally. And obviously there are huge benefits of both national and international benchmarking. Our implementation has to link back to the priorities so that the implementation is phased, so we're not fatiguing our workforce too much with trying to do too much too quickly, and with robust evaluation frameworks. So really, looking to our academic structures to assist with that. And really, the ultimate goal is healthcare improvement. So doing things better to get better outcomes for our patients and our workforce and our financial bottom line and our reputation. A structured approach like the learning health system, the IHI tools and things are really helpful. And then using that translational research approach to get cutting edge advance to the bedside as quickly as we can. Thanks.
Great, thanks. That's no small feat that you're aiming to get there, Sarah, and we'd be very happy to work with you and support that. So Robin Hudson, Robin was actually working in Monash Partners some time ago, but has been in the state government Safer Care Victoria team for a long time and is passionate about improving maternity care. And I would like to invite Robin, just in terms of, we know the state government's committed to a learning health system, and that requires engagement with many stakeholders. How do you think the state government's going to approach that, making sure that the priorities actually come from the community and the workforce, and you get that engagement as a sort of fundamental principle of successful change? What sort of approach do you think is going to be most effective in that space?
Thank you, and I'm mindful of your time crunch, so I'll try and be as brief as I possibly can be. I think certainly Safer Care Victoria has been at this for a while. Before we were using the word learning health system, we were calling it whole system quality, we were calling it great engagement with people. I mean, there were lots of different words that we have used over the last 5 years. So the way in which we do our work, and Andrew's reference the cardiac work underway, and Dominique's been part of it as part of the stroke clinical network, is that we've always been committed to gathering large groups of what we would consider our stakeholders, which will be consumers, advocacy groups, indeed our colleagues in the Department of Health, researchers, academics together. And we started that in 2018 and we continue that today with the cardiac and maternity sector coming together 10 days ago, and paediatrics on the same day, to inform us as to what the priorities are for them. And we marry that with the best data that we can pull out of the system, because as someone quite interestingly asked there about how much evidence do you need, well, actually I think we've got, to Jeffrey's point, loads and loads of evidence out there sufficient for us to act. The challenge is monitoring the quality control and the quality assurance as you take those actions, less about actually stimulus to act. So we bring together all of those stakeholders, as I described, usually a couple of hundred, and we have a conversation with the best available data and try and prioritise from there. And that includes mixing in the priorities from the minister or the government, or indeed DH, through that process. And hopefully we arrive somewhere that is helpful and useful to Victorians. And I think we have done that, particularly in maternity services over the years, with really clear differences in stillbirth, 24% reduction through active improvement work. Similarly with perineal tears, which was actually a national collaborative, because I think learning health systems operate at a team level, at an organisational level, at a state system level and actually indeed at a national level, which I think Dominic has referenced. So I think that deep commitment to working with people is what delivers the success in this, essentially. Have I been brief enough, Helena, to get you back on time?
No,
I can
no,
keep
no.
going. I can keep going. I have many post-it notes in front of me.
Wait, you've got time. Do you want to give us a few other key points? And I'm going to ask Jeffrey to give his reflection, and then if there's any questions, back to you.
I think the way that I think about it, and indeed Safer Care with the partnership we have with the IHI, is it's actually a triangle rather than your circle, because what we do is we plan and partner really deeply with whoever's most important, or whoever thinks they're most important to the decision we're trying to make. We have a clear decision-making group, which is not just Safer Care Victoria people, but it is great clinicians, great consumers, awesome academics together. And then we try very hard to get both the data that informs the decision, but also the data that is going to tell us whether we're tracking in the right way, because I think that's actually trickier to get. Pointing out the problem is super easy. And then the next is, how do you actually take the steps? And Safer Care has been working very heavily in the BTS collaborative spaces. Many of you have probably participated in that kind of work, but we're now starting to move to more campaign-like work through the 100,000 Lives, which will mean that we'll be looking to share tools in a much lighter fashion and to invite people if they would like to share data with us or not. And then looking at the big gateposts that we can draw from the system, the big kind of, did it happen or did it not happen narrative. So I think that is the direction of travel for Safer Care, and the narrowing of our priorities also, I think, is occurring with the help of the sector as well. And I honestly think that's probably enough from me, Helena. I do think passionately that if we don't all work together on this, then we are not going to get anywhere.
Yeah, well, that's what all the evidence shows, Robin. So that's really great. I know you've got this advisory group now, which is terrific too.
Yeah, we have a number of them. We have them in both. Jeffrey's part of a big one that brings in clever people from all over the place, actually, including people like Koo from Jetstar, et cetera, Kadar from the IHI, international perspectives. And then we also have advisory groups around specialist clinical areas, as Andrew has alluded to, in the cardiac piece, maternity, et cetera.
Yeah, no, that's fantastic. All right, we'll look at with great enthusiasm at how that's going to go. Jeffrey, can I ask for your reflections on those panel discussions?
I'll be very brief, Helena, because it'll liberate some time for you to make some final observations from the chair. But a couple of things really struck me. One is there's work obviously going on at micro, meso and macro levels. And those require different data sources and almost different kinds of collaborations. They all require collaborations. I agree with what Robin said and other speakers said. I'm wondering if there's almost like a mind map for Victoria needed of what's happening at the micro level, exemplary projects, if you like, what's happening at the micro, meso and macro levels to sort of illuminate progress for other people, because people need not just incentives to be on this journey, they need a bit of inspiration. And if people are making progress, it's useful to socialize that, to have it known by other people. Now, I know Safer Care Victoria is doing some of that. I wonder if that could be also done a bit more, or that sharing sort of nature. The other thing is there's a lot of talk about, okay, you need the data and the systems that gather the data in place. You need collaborations. That's been a constant theme. People have also said you need both bottom up and top down, working concertedly. You can't do one without the other. Can I just make a plea for middle out as well? You need bottom up, you need top down. But if you do that, you exclude sometimes the middle managers who are going to be the effector arms and make this work. And they're sometimes the unsung heroes. We often talk policy talk. We often talk about clinicians on the front line, but there's middle level managers right across health systems like Victoria's who make it work. So we often talk about bottom up, top down, and middle out. That would be my plea. I'm not sure if I'm adding anything or just reminding people of the importance of all the different stakeholder groups who are going to make this work.
Yeah, no, absolutely. And there's a key point here about that the stroke group is starting to do that in stroke, and indeed we've captured I suppose the successful case studies around the world, as have you, Jeffrey. I think one of the critical things we need to is build capacity in the system. So one of the things that, in fact, Jeffrey and I were discussing this morning, and just to round up, the whole point about a learning health system is it's not really a research concept. It's about healthcare and better healthcare and better outcomes for the community. And it is about collective intelligence. And often there is no safe space for all stakeholders to come together, whether it's academia or government or healthcare or community. In fact, that's what the Research Translation Centres were actually set up to do and are funded to do. And from the recent Australian Academy of Health and Medical Sciences about embedding research in healthcare are emphasised as that, that sort of safe space to hopefully work with groups. So we do hope to be able to work with you, Andrew, and Robin and others and in terms of harnessing that. But I think that one of the critical things for all of us is the workforce. Having a workforce in healthcare that understands complexity and systems change. Our clinicians do, because every patient we deal with is dynamic and complex and changing, and that's what we're used to. But actually taking that to understanding that the system we work in is complex, the solutions are not simple, and it's part of a continuing process is going to be really important. Jeffrey's got a body of work on the most high-performing hospitals, and he's about to update that. And what they have is a culture of improvement, a culture of change. They can fail, they can go forward, they can, there is a real sort of ecosystem, and then them sharing. And there's some really good examples of paediatrics, such as the Cincinnati Children's Network, where they have shared their learnings across and networks and improved together. But the data is available absolutely at the front line of care. Having it somewhere else is just not proven to be valuable. It's there for the teams all the time, and there's policy and there's all the other stakeholders involved. But having that immediate feedback, so the data is a tool, it's sufficient, but it's not adequate. And I think there's a lot of learnings to that, plus the way the capacity building across the system that's going to be really important. There are a couple of comments in the chat just to highlight about things like how much evidence is enough evidence. For most of our health services, there's more than enough evidence out there. In fact, they bring health evidence of a different nature. So the health services, for example, maternity care, see a massive increase in implementation around delivery, and a very significant increase in induction, for example, and also increase in complications. We've got the data. We know what the evidence of practice is, and we've got great obstetricians and midwives who want to change that. But in terms of how we actually do that, that needs to be obviously a much more collective effort. But it's easy to measure the outcomes. But the evidence on what to do about it is there. There is evidence on how to improve a lot of these things, but it's just hard to get it into practice. There's a few quick other points about thinking about how we, again, integrate evidence and about capturing case studies. And the critical importance of including implementation. All around the world, indeed Jeffrey's work highlights this, healthcare improvement per se in the health system is largely ineffective, unsustainable, and doesn't necessarily scale. But integrating implementation coaches with those teams, I'm just about to finish, actually can speed and very effectively show benefit. And indeed, Denise's example of that was a really good example of how you can get guideline alignment. So I'm going to leave it there, but just to say that thank you very much to Jeffrey. Great to have you, as always, very passionate talk. Thank you to our panellists. Really keen to keep working together and keep thinking through this. We also have multiple thought partners overseas in the work we're doing around learning health systems, and very keen to learn from and work with any of you and to support your journey. And also just a quick thank you to the team who've developed a lot of the learning health system through Monash Partners and MICRI. And I will leave it there. Thank you.